Hi, my name is Joel Friedlander, and I'm a pediatric gastroenterologist at the Children's Hospital of Colorado Digestive Health Institute, affiliated with the University of Colorado School of Medicine.
And I'm Emily DeBoer. I'm a pediatric pulmonologist at the Breathing Institute at Children's Hospital Colorado, affiliated with the University of Colorado School of Medicine.
My name is Jeremy Prager. I'm one of the pediatric ear, nose, and throat doctors at Children's Hospital Colorado and the University of Colorado School of Medicine.
And we are members of the aerodigestive team of the Children's Hospital of Colorado. The title of our study is Unsedated Transnasal Esophagoscopy for Monitoring Therapy in Pediatric Eosinophilic Esophagitis. This study focused on the problem in pediatrics of having to use repetitive anesthesia for the monitoring of eosinophilic esophagitis. As a group, when we started talking about this, we realized that our pulmonology colleagues, as well as our otolaryngology colleagues, do unsedated nasal endoscopy in their clinics frequently, which we had never attempted before. We attempted to demonstrate the application of adult transnasal endoscopy in pediatrics using ultra-slim endoscopes from our pulmonary colleagues as we watched them use in our aerodigestive program.
And we realized that with our combined skills, we could look at esophageal biopsies in an unsedated manner.
Over a period of approximately 6 to 9 months, 22 patients were called in sequence, with 21 out of those 22 patients interested in their children undergoing unsedated endoscopy. Those patients would come into our clinic. We would put on glasses that allowed the children to be distracted after undergoing consent. And these children would go into kind of a happy state, so they wouldn't really have to know what was going on. After that was on for a period of time, they would have their nose anesthetized with local anesthetic, and then Dr. DeBoer, Dr. Prager, or Dr. Dieterding would undergo the nasal endoscopy like they would frequently do in clinic. Once that was done, the endoscope was passed into the esophagus, where I would obtain biopsies from the esophagus, as we would routinely do for eosinophilic esophagitis, and send those pieces to the pathologist for evaluation for adequacy and to assess whether or not eosinophilic esophagitis was still present for their follow-up endoscopy. So this is a pediatric gastroscope with an outer diameter of 8.6 millimeters, which is typically used for sedated endoscopy in children. As you can see, this would be too large to go through someone's nose. This would be in comparison to the pulmonary bronchoscope, and this is one of the pulmonary bronchoscopes used for this study. And this pulmonary bronchoscope has an outer diameter of 4 millimeters with a 2 millimeter biopsy channel, similar to the neonatal scope that may be used in pediatrics. However, we also used an even smaller bronchoscope, which had an outer diameter of 2.8 millimeters with a 1.2 millimeter biopsy channel, and as we could imagine, would have a much easier way going through the nose of a child as compared to the regular scopes that we would use. We found that through the usage of these scopes and the usage of distractive techniques, that this technique was highly successful.
We were really successful at getting very young patients to undergo the procedure, which had the perception previously that it was too painful or too irritating or too long for children to handle it. And with the combination of the glasses and a team of folks that were really committed to getting the patient comfortable, we were able to do kids down to 8 years old.
The study offers us 3 areas for improvement in healthcare delivery. The first is a significant reduction in cost. The study reduces the cost for care by approximately 2/3. And these patients have repeat procedures. Overall, over time, this is a significant reduction in cost. The second area is improving the quality of care that's delivered. The care is improved by reducing the exposure to anesthetics and sedation, and by increasing efficiency and spending less time at the hospital and less work lost. The third thing is improving the quality of care for a population as a whole, in this case a pediatric population with a eosinophilic esophagitis.
This study adds to existing knowledge the application of transnasal endoscopy in not only the adult population, but also in the pediatric population. In the adult population, this is primarily used for Barrett's esophagus and for other forms of monitoring in esophagitis. This is the first study of this technique used in pediatrics and shown successful for the monitoring of pediatric eosinophilic esophagitis, which means it could also potentially be applicable to other forms of esophagitis as it is in the adult population. Additionally, because of this technique that's been developed by our aerodigestive program, likely this will expand the possibility of using this for monitoring of eosinophilic esophagitis in the adult population, which has not been demonstrated or published as of yet either. And the biopsy pieces that have been obtained by our study also are shown adequate for the evaluation of eosinophilic esophagitis.
There are a number of future implications of this study, principally the ability to apply different techniques across different fields, multidisciplinary use of techniques that may be foreign in particular fields, brought together and practiced by a group of practitioners.
We also are looking for the future of ways to refine this technique. So this technique was very much developed initially as a pilot study and was proven very successful.
We're looking at a study to really understand how often patients with eosinophilic esophagitis need biopsies. So we're trying to understand the natural history of eosinophilic esophagitis and the best ways to treat it using what we feel like are these safer methods.
We want to improve the care of children with eosinophilic esophagitis, but we feel a lot of angst about having our children undergo repetitive anesthesia to bring the care of their children as good as it possibly can be. And we've been searching for many years trying to find ways to monitor this disease without anesthesia. This technique really opens up the possibility to monitor and treat this disease much more aggressively without repetitively putting children to sleep, with the angst of families as well as the angst of us as physicians.